online anesthesia video of this week. You can also participate in this program if you are interested. Just record your video presentation on Zoom platform and send to us in onlineanesthesia@gmail.com. For further rules and regulations, please visit our FB page online anesthesia. Let us watch this week's video.
Dr. S. Sivaprasath working as an assistant professor in Madurai Medical College. He is well known by students as a great teacher. He has undergone liver transplant training in Sir Gangaram Hospital, Delhi during 2007 to 2008. He has great excitement and interest in cardiac anesthesia.
Good day to all the viewers of Online Anesthesia. Welcome to yet another episode of Video of the Week. So in this week, in continuation of all the lectures we have previously gone through, that is for spinal anesthesia, this week we are going to talk about spinal anesthesia and special situations. So why this topic? Many times what happens is spinal anesthesia is the breadwinner technique of every anesthetist. Without this, maybe some anesthetists who are in cardiac may be not using spinal anesthesia, but for a routine anesthetist, spinal anesthesia is the breadwinning technique. It is relatively very easy, very safe, and very effective. But still, when we go into practice, sometimes we have doubts whether we can give spinal to this patient or not. We call our seniors, we call our teachers, and as a beginning practitioner, I have been calling my teachers for doubts regarding whether can I give a spinal or not. And even now, when I am a teacher, my students call me and they ask doubts whether this patient is fit for a spinal or not. So broadly, there are so many conundrums where spinal anesthesia could be very challenging. And I've taken some topics which are frequently asked by my juniors, or frequently I have asked my seniors. These are anatomical spinal abnormalities, whether we can give a spinal in these conditions or not. And commonly we get doubts in patient has a coagulopathy or a heart disease, or when a patient has systemic infections. So I'll try to cover all these topics by referring to literature, because these topics would not be covered straight in books. In literature, there will be some case reports and series. So we are not talking about randomized controlled trials. And in many of these cases, I will try to add recommendations from concerned societies like American Society of Regional Anesthesia or Society for Obstetric Anesthesia and Perinatology. All these recommendations I will incorporate into my presentations. So the first topic, we will talk about anatomical difficulties. The first one is spinal anesthesia following a previous spine surgery. As early as in 1970s, there were many case reports of giving successful spinal anesthesia after laminectomy. So this one article is very descriptive, and in this letter to an editor, the author has talked in detail, and he has told that epidural is a relative contraindication for fear of inadvertent dural puncture. So once the spinal surgery is done, the dura and arachnoid fuse together, and it is very difficult to find the epidural space. So they always undergo a dural puncture. So epidural is, and finding landmarks is also difficult. So epidural is relatively contraindicated. Spinal is not contraindicated, so it can be given. The only issues we will have is there will be difficult landmarks, there will be difficulty in positioning, and sometimes patchy blockade can take place, especially when there are instrumentations done. And there are a lot of additions, you may get patchy blockade, and the level may be unpredictable. This is all these 4 points are well covered in this article by K.O. Sun in European Journal of Anesthesia. There's a pre-existing neurodeficit. It is a relative contraindication. You should always not give spinal anesthesia when the patient has undergone a spine surgery and he has already also had a pre-existing neurodeficit. And let us go to the next topic, post-polio with residual paralysis. Many times cesarean patient comes, the patient has a polio in the childhood. They have some neurological deficit as a flaccid paralysis. Can we give? So there are many case reports where they have given successfully given spinal anesthesia. And in that, if we look, can GA be given? Because if not for spinal, then we'll have to go for GA. In GA, there is one article by Lambert et al. They have in detail described about post-polio syndrome and anesthesia, where general anesthesia has high risk due to high sensitivity towards opioids and NMBs. Though it is a motor paralysis, these patients have some neuronal changes which predisposes these patients to high sensitivity to opiates and NMBs. And in animal studies, they have also shown that there is neuronal toxicity of local anesthesia at usual doses. Even small doses have shown neuronal toxicity, but they have failed to prove in adult patients. In a detailed description by Alexander Rath for a cesarean section in post-polio patient, they have told that the level and duration of sensory analgesia are usually higher than in normal patient. They have actually given spinal anesthesia for a 17-year-old girl who has had polio at 4 years of age, and for an appendectomy, that spinal lasted for 24 hours. And the same patient, when she came for cesarean section, they had given an epidural considering the previous situation, and the epidural first dose of lignocaine has lasted more than 11 hours. So this is what we'll have to be careful about. The next topic is patient with scoliosis. Many patients do with scoliosis come for non-scoliosis surgery, and what we have to remember is 70% of the scoliosis is idiopathic. It occurs in young females. It is idiopathic. Usually, apart from the airway restrictive pulmonary disease and recurrent cardiac morbidity, resultant cardiac morbidity, we will not have problems. What we will have to look into is the 30% of patients who will have secondary scoliosis, and those problems will pose problem in the perioperative period. The secondary scoliosis could be due to tuberculosis, malignancy of spine, or secondaries which occur which come into the spine, neuromuscular diseases like cerebral palsy, spina bifida, poliomyelitis, metabolic diseases like Hunter's syndrome, dysmorphic syndromes like osteogenesis imperfecta, Marfan's neurofibromatosis, and trauma. In these patients, we'll have to be careful about the primary disease which caused the scoliosis. And whenever we assess these patients, we'll always look into whether they have an airway difficulty or restrictive pulmonary disease, or because of the pulmonary disease, some cardiac morbidity. We'll also look into whether the patient has had a surgical correction of scoliosis or not. Why I'm telling this is there's a paper by Coe et al. Where they have examined 107 neuraxial procedures done in scoliosis patients. In that, they found that there is 79% success in uncorrected group. Remember, in the uncorrected group, they have 79% success, whereas there is only 69% success in scoliosis patients who are surgically corrected. The surgically corrected patients had more difficulty in needle placement, whereas in the uncorrected group, it was because of patchy block. So for uncorrected patients, it is easy to put a needle, but because of the spinal curvature, there will be patchy block and difficult to assess what level it reaches. But once the surgical correction is done, the actual needle placement is difficult. So here's a brief guideline. So we all know about the Cobb's angle. We tell that the degree of scoliosis is mild when the Cobb's angle is 11 to 25 degrees. If that is so, then if the provider is confident with the anatomy, he can proceed cautiously with good positioning. If there is moderate scoliosis, that is the Cobb's angle is 25 to 50 degrees, a paramedian approach from the convex side. So this is the convex side, that from the convex side is better. If it is a midline, then angulation should be towards the convex side, and imaging with an ultrasound is better. If there is severe scoliosis, it is better we use ultrasound guided neuraxial placement or spinal anesthesia than going for a blind one. Coming to the next part, where we have coagulopathies or platelet count disorders. The first one is low platelet count. Very frequently, we get patients who have low platelet count. They have done a test and it will show 90,000 or 80,000. We will be in a doubt whether we can give spinal or not. So this article, which came in anesthesia analgesia, neuroaxial anesthesia, and ubiquitous patient, platelet count, how low is too low. They have described in detail for non-obstetric and obstetric patients. So the SOAP Society has classified the incidence of vertebral hematoma, and they have given a cutoff value of 70,000. Above 70,000 to any amount, the incidence of vertebral canal hematoma is negligible. You don't need to worry at all. From 70,000 to 1 lakh, it is 0.2%. Less than 70%, 70,000, you have 3% incidence of epidural hematoma, and less than 50,000, you have 11% chance of epidural hematoma. So whenever it is less than 70,000, you should be little careful. Whenever it is less than 50,000, you should be extremely careful. And the spinal anesthesia should have a reasonable indication. Other than that, you should not give spinal anesthesia. In obstetrics, it's very frequent because thrombocytopenia occurs in about 7 to 12% of women. And there the definition is less than 1.5 lakh. Most common diagnoses include gestational thrombocytopenia, immune thrombocytopenia, and thrombocytopenia associated with HELLP syndrome. Other causes could be due to acute failure of pregnancy, thrombotic thrombocytic purpura, inherited thrombocytopenia, and sepsis-induced thrombocytopenia. So what do we do when the platelets are low? Usually we think that whenever we have low platelet count, there are platelets which could be active. So we think we can use the platelet function analyzer or thromboelastogram, and if it is good, we can give a spinal. But the evidence suggests that only bleeding time and platelet count are useful to decide whether you can give a spinal or not. The platelet function analyzer and thromboelastogram have no role in deciding whether you can give a spinal or not. And if it is really low, whether a platelet transfusion can help you in giving a spinal, there is no evidence for that also. So you can give when the range is 70,000 to 50,000, but avoid spinal if the patient also has an inherited coagulation disorder or the patient is in DIC, patient is concomitantly taking antiplatelets, or there is spinal canal stenosis or scoliosis. So above 70,000, it is really safe. 70 to 50,000, if these three conditions are there, don't give. Less than 50,000, never give spinal anesthesia unless it is really indicated. So that is the take-home message here. And coming to antiplatelet drugs, we have thromboxane inhibitors, we have P2Y12A inhibitors, and the recent drugs. Aspirin, I have talked about both ASRA and Association of Anesthesia guidelines. Aspirin, they have given that there is no precaution at all. So you can proceed with any spinal anesthesia whenever the patient is on aspirin, and the same is for NSAIDs also. For clopidogrel, you will have to be really careful. The ASRA guidelines is 5 to 7 days and AO guideline is 7 days. So you have to stop the drug and then only give. For prasugrel, it is slightly higher in ASRA guidelines. It's 7 to 10 days and it's 7 days in AOA. Ticlopidin, it is 10 days. The longest duration is for ticlopidin. It should be stopped for 10 days. Ticagrelor, cangrelor, it is 5 to 7 days and 5 days. And cangrelor is a very short-acting drug. It is given IV. It can be stopped 3 hours prior to spinal anesthesia. And coming to glycoprotein 2B3 inhibitors, abscesimab has the longest stopping time. It is 24 to 48 hours. And AOA guidelines safely gives it as 48 hours. For tirofiban and eptifibatide, it is only 4 to 8 hours. Maximum after 8 hours, you can give a spinal safely. And dipyridamole, it is given for stroke prevention. At least 1 day it should be stopped. And cilostazole is given for thromboangiitis obliterans to prevent clotting. So that should be stopped for 2 days. This is in brief. And I repeat that for aspirin, you did not bother at all. You can give a spinal. For clopidogrel, it is 5 to 7 days. For prasugrel, it is 7 to 10 days. And for ticlopidin, it is 10 days. Mandatory, you have to stop the drug and then only give spinal anesthesia, or the chance of epidural hematoma is really very high. And there's a special group of patients with hip fracture and on antiplatelets. So in AOA, they specifically tell that 30 to 40% of hip fracture patients are on antiplatelets, and the risk of vertebral canal hematoma is less. Though the patient is taking antiplatelet, you still have to proceed to surgery, because delaying surgery for more than 2 days poses more problems in these senile patients. So any antiplatelet, if it is a single drug, whether it be clopidogrel, prasugrel, or whatever drug it is, a single drug when it is given to a patient, it's not a contraindication spinal anesthesia given by an experienced anesthetist. But when there is a dual antiplatelet, it is better to go in for GA and go for surgery as early as possible. So this is the latest recommendation given by AOA with regard to patients with hip fracture and on antiplatelets. So let us go to patients who have coagulopathies. We'll discuss 6 issues. First is hemophilia. As such, it is not a contraindication. If we can correct the coagulation factor values and the spinal is really necessary, you can have a hematological consultation and go for a spinal anesthesia. For major trauma and massive transfusion patients, it is not at all recommended because together with that, they will have DIC, hypothermia, hemodilution, acidosis, inflammation. So you will have both bleeding risks and infective risk and other physiological risks. So it is better not to give spinal anesthesia in a patient with major trauma. Coming to sepsis not only will risk the patient to CNS and meningitis, they also have procoagulant state, thromboprophylaxis. The patient will be on thromboprophylaxis treatment and DIC. It is better not to give spinal anesthesia in this patient. The main concern is meningitis and epidural abscess. So don't give spinal anesthesia to a patient who is in sepsis. And a patient who has liver failure, it is always a high risk group for regional anesthesia. But what happens is liver failure, we always have some difficulties in giving general anesthesia because of drug metabolism. However, if the INR is less than 1.5, they are still acceptable for spinal anesthesia. In uremia, the same problem is there. The GA has some increased risk. But when you give spinal, you can give spinal anesthesia. But what you will have to do is you will have to remember the patients will have low platelet count, altered platelet function, and there will be residual heparin function after dialysis. What happens in DIC? DIC, neuraxial blockade, spinal, epidural, small needle, whatever it is always unsafe. Don't give. So we'll go to anticoagulant drugs with holding time. The commonest anticoagulation drug which is used in government setups is unfractionated heparin and it's given subcutaneously. If it is a low dose, that is 5,000 units BD or TDS, stopping it for 4 to 6 hours is absolutely okay. You can go ahead for spinal. If it is a higher dose, that is 7,500 to 10,000 BD, or the total dose is less than 20,000 per day, 12 hours have to be elapsed after you, then only can give spinal anesthesia. And if it is a therapeutic dose that is more than 10,000 or 20,000 units daily, you should wait for a day before you can give spinal anesthesia. The AOA recommends 4 hours only, and they ask you to check for APDT. And if it is less than 40 seconds, you can safely give spinal anesthesia. If it is given IV, you can go ahead with the spinal anesthesia once it is 4 to 6 hours. So the recommendation for low molecular weight heparin is if it is given as a prophylactic dose, 12 hours stoppage is necessary. As a treatment dose, 24 hours is necessary, and consider checking the anti-factor 10A level before giving a spinal anesthesia. For fondaparinux, we usually don't have recommendations and they don't recommend spinal anesthesia when the patient is on fondaparinux. At least for 2 days, it should be stopped. For oral drugs, that is factor 10A inhibitors, rivaroxaban, apixaban, and edoxaban, the general precaution is 72 hours. You have to stop it for 3 days, and more so if the patient is having a renal failure. And for direct thrombin inhibitor, dabigatran, it is the longest period. It is 120 hours. If there is no additional risk, if there are additional risks like if the patient's renal failure, it is better to avoid the spinal anesthesia at least for more than 5 days if the patient is on dabigatran. And for warfarin, it is ideal to stop it for 5 days before INR is normalized. AOA recommends INR less than 1.4 before you can give spinal anesthesia. And for thrombolytic drugs like alteplase, retiplase, and streptokinase, at least 48 hours should have been elapsed, and you should document normal clotting factors, including fibrinogen. AOA recommends you should not give spinal anesthesia for 10 days. That's a pretty long period, but for 10 days, like ticlopidin, you should not give any spinal anesthesia for a patient who was on thrombolytic drugs. Coming to cardiac drugs, we'll cover 4 problems: pulmonary hypertension, valvular heart disease, congenital heart disease, and cardiomyopathy. For this, I have referred standard textbooks of obstetrics because commonly these patients will have problems, and I'll just give you a guideline what you can do. For pulmonary hypertension, it is better to avoid spinal at all because pulmonary perfusion in these patients will be dependent on right ventricular preload. So if you give a spinal and that venodilatation causes a reduction in the pulmonary flow, it can impair systemic oxygenation. So it is always advisable to go ahead with an epidural than a spinal. But there are reports of ultra low dose spinal for elective hip arthroplasty, as in this case, where they have inserted a epidural spinal catheter and given ultra low doses of spinal anesthesia repeatedly, and these patients have come out very comfortably. But if you don't have such a need for a low dose, it is better not to proceed with spinal anesthesia for a patient who has pulmonary hypertension. So next problem is left-sided obstructive disease. For regurgitation lesions like mitral regurgitation, aortic regurgitation, it is safe to give spinal anesthesia provided you have knowledge of what is happening in the patient. There should be good monitors. You should know what level you are in need of, and the dosage you are going to give should be predictable. You can go ahead. But when there's a left-sided disease like mitral stenosis or aortic stenosis, where the patients are dependent on the systemic vasoconstriction for the tissue perfusion, it is better you avoid the spinal. Very rarely when I have been presenting in conferences that you should avoid spinal for these mitral stenosis and aortic stenosis patients, there have been anecdotes of senior anesthetists giving spinal for these patients and having an noradrenaline infusion or a phenylephrine infusion. But whatever it is, you should be able to maintain the stroke volume and still prevent pulmonary edema from coming in these patients. So when you opt for a spinal in these patients, you should remember that the valve area should be more than 1.5 centimeters square. Less than that, your tissue perfusion will be greatly impaired. These patients should not have pulmonary edema. Patients who are already in pulmonary edema, if you give spinal anesthesia and make them lie down, it will aggravate. Even though sometimes the preload will reduce and the pulmonary edema might become better, it is advisable not to give a spinal anesthesia in a patient who already has pulmonary edema. There should not be any atrial fibrillation. Pulmonary hypertension should not be there. Patient should not be on anticoagulation. And pharmacological management of SVR should be possible. That is, it is not giving an ephedrine or mephentermine. It's giving phenylephrine or noradrenaline as an infusion. That should be there with you if you contemplate to give a spinal anesthesia. And the risk of GA should be higher. See, these patients might have a severe airway difficulty or a pulmonary problem. That should be there when you opt for a spinal in patients who have mitral stenosis and aortic stenosis. For congenital heart diseases, if it's a cyanotic heart disease, spinal anesthesia is not recommended. You should not give, because reduction in SPR will greatly increase the right to left shunt, and the patient will become very hypoxic if you give a spinal anesthesia. For acyanotic heart disease, you can give spinal anesthesia. For an ASD or uncomplicated VSD, you still can give spinal anesthesia, provided that the mean pulmonary artery pressure is less than 40 millimeters of mercury. That is the cutoff limit. If the patient has pulmonary hypertension, that is the mean pulmonary artery pressure is greater than 40, there is risk of shunt reversal, and spinal anesthesia not recommended in these patients. For cardiomyopathy, if the patient has ischemic or hypertrophic cardiomyopathy, spinal anesthesia is definitely a contraindication. Ischemic cardiomyopathy has a high risk. You still can give if you can maintain the aortic diastolic pressures, but if you give a spinal and the aortic diastolic pressure is going to go down, ischemic cardiomyopathy might worsen. So don't give spinal anesthesia in these patients. For dilated cardiomyopathy and peripartum cardiomyopathy, a carefully titrated CNB is always advisable. Spinal anesthesia is still acceptable, but it is not the choice. Epidural is the choice. So coming to the last part, I still remember the first question my professor asked me when I joined my post graduation. He asked me what is the absolute contraindication for spinal, and somehow it struck me that infection at local site, and that made me bond with my professor a lot. So there are many infections like HIV where spinal anesthesia has been given, but the most common query which we get is when the patient has a chicken pox and they come for cesarean section. So I have referred to many recommendations, and all of them tell to avoid spinal anesthesia for at least 2 weeks after the onset of symptoms due to risk of meningitis, especially when the patient has pustules or the papules are erupting. The patient is at the highest infective stage. Never give spinal anesthesia at that stage. If you have to give, the recommendation is to use a pencil point needle, and that they have suggested that it might reduce the risk of meningitis. But my take is don't give spinal anesthesia in a patient who has varicella. But the other side is, if you give GA for a patient who has varicella, that patient might develop varicella pneumonia, which is really dangerous. If the patient has immunocompromise or severe pharyngeal lesions or a compromised lung status, definitely this patient might land up with varicella pneumonia. In that situation, spinal anesthesia may be useful. Exposure to OT personnel is higher when you give GA. So that also you should consider. To summarize, we have discussed about anatomical problems, that is spinal anesthesia after a spine surgery, scoliosis and poliomyelitis. Bleeding disorders, we have discussed about platelets and coagulation disorders. And in physiological problems, we have discussed about cardiac diseases and infective diseases. We have discussed about problems when the patient has a varicella. So these are the common conditions where spinal anesthesia, whether to give spinal or not is doubtful. So you can use these guidelines and go ahead, and still the queries will be more. You can have a lot of situations where you will have to doubt. You will have doubt. You will have to refer to peer-reviewed articles where because you won't have randomized control trials. You will have to review articles and then ask your seniors and other. You have to use your decision making whether a GA is safer or spinal is needed, absolutely needed. Then only you have to give spinal anesthesia. Thanks for the opportunity. Thank you very much. You can ask doubts in our group whenever you have a problem. Thank you.